Uh, All right. So I'm Cami Peterson DeVries. I'm vice president of St. Francis Health Services, which I oversee 14 nursing homes, 10 assisted living, and nine independent living, with three of those being HUD. And so I'm very have been involved in a lot of my career in the elderly care. I also am an adult geriatric nurse practitioner, and I have what I say is a small practice of about 70 to 80 patients in a private practice that is just my own practice. I kind of inherited, I was very fortunate to inherit it, in a sense that when I was training as a nurse practitioner, the person I was training with was actually leaving, and she said, "Do you want to do my practice? I have some people." And I actually take care of a lot of Amish Mennonite in rural Minnesota. So I have a unique practice in the sense that I work very holistically and then do medications as needed. And so kind of we start with the whole person and that kind of stuff, because that's kind of where my patients have brought me to be. So pharmacogenetics is really a passion of mine, and we are doing some things in elderly care that I'll talk about. So tonight our objectives are to describe, the interconnection of medications and health outcomes, define methods of using pharmacogenetics. And I'm just gonna, for the sake of not having to always stumble over that, I'm gonna call it PGX. It's a lot easier to talk about that. And so we're gonna talk about methods of using that in interdisciplinary practice, and then really information on opportunities that we all have to be able to work with this type of what I would call as precision medicine, and how it really can impact population health and really address some of our health outcomes that really have people ending up in the hospital, ending up with falls, all those types of things. So first off, why PGX, right? Like, why is it that we want to do this? So what we know is pharmacogenetics, it helps identify patients who are very high risk or have a very low likelihood of responding to different medications. We really want to look at what we call precision health, right? We know as nurses, and we know as research people, that oftentimes medications are really tested on people who are in that age between, anywhere from 30 to 50, and healthy, usually, individuals. And we often find that they're not really intended to be, really, until we know what the side effects are. It's really about the negative outcomes of the medication. And then all of a sudden they get, from an elderly perspective, they get on the Beers list that says, "Oh, this isn't a good medication for elderly." But it's only by default that we get that, meaning that there's poor outcomes on that. I'm sorry, just one moment. My cat. I'm so sorry. She was scratching at the door. So the pharmacogenomics really helps identify a patient with higher risk of serious adverse effects. It also helps us identify those medications that may or may not work, all based on genes, all based on what our genetic makeup. So pharmacogenetics it's really effective the genetic variation on a drug response. And so it really looks at the disposition, the safety, tolerability, and efficacy. And then the pharmacogenomics, and they use these terms, if you look and watch the research, they use these terms really interchangeably, but that is really employing the tools for surveying the entire genome to really look at the determinants of that drug response. So it's really taking a look at taking a tool and looking at what we're going to talk about tonight is really swabbing people and taking that tool and really looking at the whole system of genes and what the response is going to be to those medications. So any questions? Oh, okay. So I'm going to just do a brief gene review. In general, we all have what we call CYP enzymes. And these enzymes are really involved in about 75% of our drug metabolism. So when we start to looking at the PGX testing, overall, we are looking at some of those enzymes to determine how our medications and how an individual's body is going to metabolize that drug. We also look at the TMPT. That enzyme is actually what carries out a chemical reaction through the gene system. The ATM gene, which is involved in cell cycle control, which really is the gene regulation and how it oxidizes the stress of any of that chemical or any of the cellular changes that a medication may do. And then the VKORC1 gene, that is really provides, it is the gene that actually helps make vitamin K. To use that enzyme, we're going to look at the factor V Leiden, which is the mutation, of course we know that, of the clotting factor, and then the MTHFR, which is assisting in metabolizing folate. The reason why I want to do the gene review is because when we look at what our test results are, it is these genes that they actually look at in how our medications are metabolized in individual people.
Tammy, are these covered through Medicare, commercial insurance, or is it out of pocket?
So Medicare actually does cover it as long as you meet some of as long as the medication that they're taking is one of those. So when you see the list, you'll see I'll show you a sample, a case study of mine, and you'll see all the medications that are listed there, and if anybody is on that, Medicare will pay for this. Insurance is questionable. I have not had insurance turn it down, but the company that I work with, it's only about $300 to run it, and you only run it once a lifetime.
Oh, that's good to know.
Yeah. So because our genes don't change, right? So that's been some of the misnomers about it when I worked with physicians on this, or pharmacists even. It's like, well, when are they going to have this again? And it's like, well, genes don't change. This is one time. So I really feel from a perspective of population health and from the care related and the ability to do precision medicine that we have to do better. And, when you look at this is where we're at today. 30 to 60% only respond to drugs. And the rest don't. When we can start to look at precision medicine, the drugs that couldn't be prescribed would be 100%. And those that don't respond would be 0. And when you really think about that, you think about what a waste. If we've got only 30 to 60% of people respond to medications, you think about what a waste of some of that from a financial, from poor health outcomes, all those things that really can impact the way really people's health and the way that people feel. So some of the studies, and some of these studies are some foundational studies. PGX has been around for quite a while, I was looking back, and I believe that I started to get interested in it about 10 years ago, where I started to keep little in my files, little things about it, about genes. And, it was really started to use in things like when we started to hear about breast cancer and breaking down the genes around breast cancer and how we were doing chemotherapy to address that. It was also found that they were doing that around mental health drugs, antipsychotics and those type of drugs. And so they were really doing some of this in those realms a lot more than we were really looking at in general practice. And so some of the studies that I pulled was really with the Cleveland Clinic Journal of Medicine, and just really that says, integrating this really into our clinical practice has the potential to really improve outcomes of treatment and really look at the morbidity and death, and also to be cost effective. NHS has some things that they are working on, and if you go onto their website, there's a lot of data on PGX and a lot of data on how it really can improve care. And so it's really it is evolving. However, it has been really difficult, and we'll talk about that, really kind of difficult to get this into practice. And let me see it. Yes, Savannah, that's right. They were very specific to certain groups of people. You're absolutely right. And it was really specific to medications. There's also some health disparities that occurs with this right now because people, we know that there's health disparities with minorities, and there's and certain populations of people. And unfortunately, those providers that assist in providing care to some of the minorities and some of that don't always have the resources to be able to provide this information to their patients. So, and then looking at the Health and Human Services and really feeling like with our electronic health records, with the pharmacological things that can be integrated with pharmacy, with all of this, that eventually we should see this becoming a routine part of practice. So other just further resources, there is this Clinical Pharmacogenetics Implementation Consortium. It's an international consortium. Really who there is on the website, there's actually some ways to implement this type of thing, the type of practice. There's also some resources there on some of the research on genetics and all of that. One of the position statements from the American Society of Health System Pharmacists believes that pharmacogenetics testing can improve medication-related outcomes across the continuum of care in all healthcare settings. And I just think about, what does that really mean in the care that we give and provide? And then really the precision medicine carries the potential of improving at both the individual and at the population level. So it's reasons why, right? Because there's just all kinds of reasons why we need to look at this. And I think that for me, it's always kind of a challenge, because I think, how can this just not be so clear to everybody that this is what we need to do? And it just is not. But really, the reasons why we need to do this is really to look and predict a patient's response to drugs, to really customize what we're ordering, or what a physician is. And if you're not in as a practitioner, but you are in as a nurse at the bedside, looking at these testing and going and saying things like, wow, I looked at their genetic testing, and this drug isn't probably going to be effective for them, or this drug really could have some adverse effects of that. And taking this information and really using it just like we use any other lab tests that we have, any other thing that gives us information on what's going to be best for our patients. whether it's at the bedside, whether it's in a clinic, whether it's in our nursing homes, in anywhere that we provide care. This can improve care. It really can look at minimizing or eliminating adverse events. It really can improve the efficacy and compliance. Well, sorry about that. And it can really, it really can improve the accuracy of appropriate dosage of drugs. As I mentioned earlier, in the long-term care or with our elderly, and if you've been practicing or working with elderly at all, we've had the Beers list for a long time, which tells us, oh my gosh, that drug isn't good for those elderly people. However, it's only after there's been really negative outcomes and then everybody's lumped together. If we look at precision medicine, that Beers list, that drug listed on the Beers list may not really be it may become the drug of choice for your individual patient or resident or client. And so that's where we get away from this population of everybody's treated the same to really being at the point of this is what is meant for this individual. So I think that it's always asking as we all look at precision medicine, we have to address why it's so difficult to implement. Why is it? I'm sure there are a lot of theories, right? But from my perspective, one of the major theories that we have is that we have a healthcare system that's really built on people being sick or addressing that versus really looking at what can really be the best for people. And so it's really not widely utilized in clinical practice. Some of my patients that come to me, I order the test and they don't want me necessarily to be their practitioner, but I'm one of the people that they know they can get this, and they bring it to their own provider and sit with them. We're starting to see providers going, wow, this is really good information. In fact, I have a patient right now that the test was rejected, and he said, well, I know my doctor's really interested in what you're going to give me when I get it back and I have to retest him. But people really, it's a really good opportunity to have really good discussions about how individuals should be treated. And we have this, that comes from, we have this kind of group thinking on that this medication works for this disease or this illness, and everybody gets prescribed that instead of really looking at it. Dose adjustments, maybe on the basis of renal or dysfunction can be accepted, and so when we look at things, we go, oh yeah, that's a drug that actually is processed, through the kidneys, and their kidney function isn't very good. So that's very concrete, and we can and that makes sense. Whereas this DNA stuff doesn't always make sense to people. And so there's just really hesitation on that. And sometimes it's just really people being unfamiliar with what the genes can really tell us, what's the genetic compounds that information that we can have. And there's not as much comfort in that as there is in these other types of tests that we can do that give us information. So we're going to talk a little bit about a patient of mine, and I'm going to show you what I have. And I think I have to, I think I need to escape here and pull up this. Now, let me see if you can see my screen, but not my Teams. Can you see this at all?
I see case study.
Okay, so you're seeing my PowerPoint still. Let me, for some reason my thing is not coming up. All right, There. Can you see it?
Yes, we can see it.
All right. So I'm going to tell you a little bit about this patient. This patient came to me. She'd been in and out of the emergency room and the urgent care multiple times for major headaches, confusion, and not feeling good. And she's not that, I mean, she's not that old. She's, 71 at this point. And so she came to me and her medication list. So how this works is that it is a buccal swab. You take the swab, you circulate it in the cheeks, and you send it in. And so she came to me because she had heard that I was doing this type of testing and wanted to kind of figure out if her medications that she was taking were a problem or not. And so literally, I think that in about 5 months, she'd been in the urgent care 3-4 times, in the ER at least twice, for major headaches and dizziness, confusion, all those things. So we did her DNA, and so this is where I wanted to show you those genes. So here you can see the genes listed, and you can see that there's an intermediate, I don't know if you can see this, but there's an intermediate metabolizer. There's a rapid metabolizer, normal metabolizer, and a poor metabolizer in the genes here. Okay, so this is her genetic summary.
Can I ask a practical question about this? So, since this doesn't change and it's something that should presumably follow a patient wherever they get practice, does this have a place in the EHR where every provider can easily access this information?
So this is done by Integrity Sciences. They do have a portal, and somebody would probably have to download it. So I go in for my patients and pull theirs in, and I just pull it into the EHR, but I don't have like an Epic EHR or any of that. I have a pretty simple EHR. But they can pull it down from the portal. One of the things that I do is I do send this with the patient, the whole thing, and it's several pages. You'll see that. We made the decision in our 14 nursing homes, actually 13 at the time, because we just got merged with another one, but to have this done in all of our residents. We did it as a falls intervention review, and we felt like maybe we can do better outcomes if we actually did PGX testing. And so all of our residents in our nursing homes get PGX testing. It was a hard sell to some of our physicians. And at one point, even our pharmacists, because in a nursing home, we have pharmacy consults every month. And so we got our pharmacists involved, saying we'd like to do this. And at one point I was meeting with pharmacists, and they said, well, what's your risk of doing this? And I said, well, what's our risk of not? And he said, good point. When we know we have this available, what's our risk of not doing this? How would we not see this as a benefit? And so there was just this whole thing. So in our nursing homes, we have our pharmacists work with the physician on making recommendations, because that's what our pharmacists do in nursing homes. In my own clinical, and what we do is we test people, and then if they are discharged home or any of that, this just goes with them. So that our hope then is after they've left our transitional care units or any of that they have resources that they can continue to have good care. So you can see the differences in the genes. So what happens with this is they get this personal kind of genetic summary. This is all for them. And I can make this a little bit larger if that would help. How's that? And then, is that better?
It is, thank you.
You bet. So then what we do is that this is the medications that she was taking. So they will list here. And like I said, there's different companies that do it. This is just the company that I work with. But this was her medication list. And they kind of put it out into risk categories: higher risk, lower benefit, or not. And they do this kind of ranking as to what level. This little icon here says that this is a gene issue, and that this is a high risk, low benefit for her. And so the rest of them were pretty good. They also do a risk score or an alert score above, and all of that has all the categories and the scores above here. But her score on this one was a 5. So when I met with her, that was the drug, that we talked about. So that's Lexapro. That's, I still can't get used to these generic names. I don't know about some of you, but so her Lexapro was one that I really did. The rest of them did not look too bad. She was taking, of course, a couple of medications for migraines, but they weren't consistent. But the consistent drug that seemed to be a high risk for her was the Lexapro. So that ends up being her makeup here of where her drugs are falling. Then you go down and it gives you kind of some of the possible summaries. It gives you a summary of possible issues that they're having. And I always review this with our patients. And you can just see, just some of the lifestyle, some of the interactions, things that we know as nurses that we know. And then there ends up being, this looks at just her risk factors, and she really had no other risk factors. There was really not, from a medical perspective, there really wasn't a reason for her to be having to make these ER and urgent care visits. There wasn't really a logical reason for her to be having all this stuff going on with her that was going on. So it gives you your kind of the risk factor guidance and that type of stuff. And then here is the comprehensive drug panel that it tests. So it has 3 columns. It has the standard, and then it has kind of this area that says this is information and caution, and then the other that says consider some alternatives. Now they list all the medications that they actually test for in the genes based on their genes, what is going to work or not work. And so you can see there's cardiovascular. So Heidi, this is the list of drugs that if anybody's on any of these, Medicare will cover the expense of it.
Oh, that's great.
So
it would be so great if this is, and I'm thinking like an informaticist, but if somehow this was embedded into the EHR so that there would be a flag that would go up, if somebody tried to prescribe something that was, one of those risk or not useful meds, that would be so great.
And that's what the Health and Human Services says should be occurring, right? That this should be able to be integrated into those EHR systems to really maximize the benefit of it. But you can see, so there's anticoagulants, antiplatelets. It goes through other beta blockers, channel blockers, and then the statins that we know can be problematic for people. diabetic medications, GI medications. And so the reason why we make sure that our residents that leave the nursing home and my patients get a copy of this is if ever they needed any of this, their physician or their provider, if it wasn't me, could actually make a healthcare decision based on what might work for them based on this list. Here's a flag that says based on, and this is based on her genes, this would be a caution medication for her. That's an antifungal. Anti-anxieties, dementia meds, mental health, depression. And then you'll get down. Now you can see where her SSRIs are sitting. Definitely had some genetic issues. So the thing that I changed her to was Paxil. And this was back, well, let's see. We did this in January of last year, and I don't believe she's gone to the ER since for a headache.
Wow.
Good job.
Well, it's fun. It's fun. And you know, this can be anybody, right? We know our residents are falling less. We know that we're seeing better eating, less weight loss. The things that we're seeing just because we're paying more attention to this stuff. But you can see all the medications. And you know, we know that Medicare won't pay for things if they don't feel it's valuable. And so they just do a lot. Here's your NSAIDs, opioids.
That's so important for pain relief when we're working with cancer patients and other people with pain that can't be relieved. And they
Yeah,
just, the standard prescription, you know, one size fits all, and it just doesn't work.
it does not.
And we've
Well,
known this for a really long time.
right. Well, and Martha, we all know that, right? Somebody can take a Tylenol with codeine, Tylenol number 3, and be out for 2 days. Another person takes it and it doesn't work at all.
Right. And I've been arguing with physicians for a lot of years about that.
Yep. Yep. So this really sets us up, again, it sets us up to be using it as really in good practice and good education and being able to work with patients on what's really will work for them. And again, that population health can only improve for the exact thing that you're talking about, Martha. And so then it just talks about some guidance here, and it does give this report will give some of the genes evaluated and what it showed in those things and why. So it's quite a long report, and one of the things that we really had to work with was because people can get overwhelmed with the report, right? One of the things that we really had to work with our providers is that you don't have to read it all. You have to look at the chart, determine where people are at, and then you have to look at what are the alternatives based on what they're taking. The rest can be when we talk to the physician. So what we've done in our organization with our residents is that, as we know, that when a nurse in the nursing home calls the physician always does what the nurse asks them to do. So we've actually taught our nurses to pull this out and say, okay, we've got something going on here. But according to their chart, this might not work for them. This says what it says it will work. But even our nurses sometimes get a little like, oh, I forgot to do that, or I forgot to let them know that that won't work. And so that's where, again, we have kind of in our nursing homes, we have the gatekeeper of the pharmacist to really help make sure that we're following it. And then this is just the summary of their genes again. And a quick little list. So that is the case study, and I'll close this and do another and open up my PowerPoint again.
Cami, how long have you been doing it in the nursing home?
We started a year ago. So actually a year this month, because I started to say, let's get it done by January of 2023. So it's, it's been, and we are seeing some good, we're seeing some really good results. And, sometimes you don't always know even what the results are, right? Because of your data. Sometimes it's hard to know what's going well. But I can tell you that when we have a resident that's fallen and it's like, okay, let's pull out that PGX report. Is there anything in there that we've missed? Anything in there that we need to pay attention to? And there are times that we have had where that the physician hasn't gone along with it. And then we still continue with outcomes, and then eventually they'll go, okay, well, we'll try it. Because we're like, what do we have to lose at this point? Because the outcomes are not good. So I think that using the information and it, again, from a frame of reference, it makes sense that we do it like any other lab test that we do. Like, we make decisions in healthcare based on those types of things. And so it's really about making sure that people understand that we can do this. It's as accurate as it is as a blood test, and that it can help in population health, and it can assist. And using this in a manner to really impact people differently. And if, I think sometimes it's hard because patients don't always realize that how research is done for medications. Patients don't always realize that their medication they're giving is just the standard protocol that's on some form that says this is what we got to give. Or we're treating, this is what we treat, and we start here and we give this medication. If that doesn't work, then we go to this one. And if that doesn't work, we go to this one. A lot of times patients aren't aware that that's how we prescribe, or that's how their doctor is prescribing. And so looking at having patients be empowered to know what might work for them is really a great way to impact population health. So I just say, isn't this the best for our patients and public health? Like, for me, it just seems like such a no-brainer. And like I said, I'm pretty passionate about it. But it really does maximize the efficacy of drugs. And isn't that the goal of drug therapy, is to maximize efficacy and minimize toxicity, right? That is the goal. That anytime somebody gets medication prescribed, that is the goal. This can help predict a patient's response. Are they going to respond to this versus this trial and error that we currently have? It gives us options that may really assist people in their own well-being and really having optimal health. And then really the opportunities really for practice are just so many. This can be at the bedside, in the hospitals. They can take that report, share it with their physicians. They can take that report, bring it to the nursing home, making sure that it empowers patients to understand and know what's going to work for them as individuals. And so, it really is that one size doesn't fit all. And that is our current approach, that everybody's treated the same. And when we can take an individualized approach, drug and or dose will be chosen for each and every patient, with each and every patient's outcome being the best that can be for them. And so that's how I think we can change healthcare. Questions?
You know what stands out to me, Tammy? I wonder how much of practice is driven by up to date. Always do this medicine for this. Well, insert guideline here, but and I really wish there was a pause point before the guideline application to say, what is this, the pharmacogenetics say, and then from there make an educated decision.
Yeah. Agree.
I worked with an orthopedic surgeon who learned in medical school that the appropriate rate of an IV was 90 cc's an hour. And in his over 50-year career, never deviated from that.
Wow.
No matter what. So there are people who learn something and then that's just going to be what it is. But my question is, I wonder if this could help with disparities, racial disparities, and male, female, age, all kinds of things.
Absolutely. And I think that, I think until it's more widely spread, because disparities fall in many categories, right? It's not just about their genetic health disparities, but it's also about access to care. It's
Right.
also about cost of care. It's about all those things. And until we can get a system that really supports this, globally supports it, where it is a standard of practice, that everybody has this at their fingertips, and it really could help. And if only 30% or say in the middle 50% of the medications are working, how many people who have poor health and have either racial disparities or income disparity, any of those things, and they're wasting their funds on things that aren't working.
And blamed.
And blamed. Right.
Looks
So
like Celeste has her hand up.
Yeah, Celeste.
Yeah, I'm wondering, because I really love this idea of a population health standard of care. What are your thoughts on, let's say that universally this did become a standard of care? What would the next, everybody did this at a wellness checks, for example, once, and then would it be reviewed by pharmacy, primary care? What would be the best way that would be standardized so that somebody wouldn't get this done and then not have anything followed up on it?
Well, I think that I think it's like, we've got some universal systems now, right? For the most part, we have the ability in from a pharmacy perspective, that they can have some of this data and assist, right? And in some countries, the pharmacists do even the prescribing, right? And so I think that having it in both locations, that a primary physician has the copy of it. I look at it similar to, why wouldn't we have it similar to a DNR or any of those kinds of things that's available to people? Because you're right, Celeste, it's not going to be useful if people don't look at it. It's not going to matter. So if somebody can do this at a wellness, it goes into an electronic health record. That electronic health record is shared in between the clinic and the hospital and the pharmacy. That's going to be ideal.
And then the next step of practice would be no medication is ordered without reviewing that.
Correct.
Yeah.
And that's kind of what we've done in the nursing home.
Okay.
Is said, wait, let's not get anything on board unless we've looked at it at the PGX to see. Because in our nursing home, we've got the frailest of the frail, right? And if we can avoid something, and you know, in the nursing homes, we've always had that start low, go slow. But you know, we can do better by saying, wait a minute, even that could cause harm to someone.
Thank you.
Other questions? Quiet.
Are you
How much,
keeping?
I have
Oh,
a
go ahead.
question. How much
Go ahead.
research is being done and by whom on this particular topic?
So the CDC actually has quite a list, and the Health and Human Services has quite a list. And so we're getting some government agency, and there is a whole genetic component of the government that is actually doing more and more research on this. The research goes back to probably the early 2000s, around when they started to use it under under psychiatric, those kinds of times. That's kind of where they started. And then you'll find a lot of it on genotyping things like for breast cancer or for cancers. There's a lot more of that precision medicine happening, and it's a very similar process. It's just that you'll find a lot of research on that. It just has not been as focal as much as it is not becoming now in looking at it as a whole, because it's been very fragmented into those kind of sections of care, just like our healthcare system normally is. It's fragmented care, but there's a lot of research on it now.
Good.
Yeah.
It'd be nice to see some more by nurses though, you know, with the kind of physical care that you're talking about. Yeah.
Yeah. Yeah. So I'm working with Leading Age Minnesota, and they got a grant, a $50,000 grant, to actually work with the Minnesota Medical Directors Association and the members. I'm on the board for Leading Age Minnesota. And so the clinical nurse, the VP of clinical services there, and I go back a long time. And so she had called me one day and said, I'm really looking for a project. There's a grant out there. And I said, oh my gosh, this would be a great opportunity. So her and I actually are working on that. And I think that getting it out into populations that are physician driven, like the Minnesota Medical Directors Association, and starting those things is going to help us globally get this more integrated into other venues of care. And so we're hoping to actually work a little bit with the University of Minnesota. I'm not sure what her contact has been yet to do that, but there may be some more research coming out of this.
So
I'm
are there
curious to know
nursing home
what-
conglomerates like yours that are doing this test on all their residents in Minnesota?
We are the first we are the first real company that's doing it globally like this. Cassia Nursing Homes, they actually are looking into it. They really haven't fully integrated.
I don't know if I had the wrong cord.
They haven't really fully integrated it, and so they were just starting, but we are leading the charge in our nursing homes.
And then do you know of any clinics or primary care practices that are doing it?
I've heard that Centricare has been doing it a little bit, but I haven't gotten enough information on it to know, because I had gotten some things like, well, it's really expensive, and we do similar. So I was at a conference this fall, and somebody from Centricare was there, and they said, well, we just kind of do this, but it's kind of expensive, and we do it in our own lab. And so it didn't sound exactly the same, but they're trying to get on the track.
Hmm.
Now, I haven't found, the patients that I see are from different healthcare systems, and I haven't seen it globally used. But I did have a student that did, she said, I want to get this for, because I've been trying to train students, right? Where do you start? You start with the students because they change the world, right? They
Yeah.
change our world in the future. And so she said, I want this to get this for her mom. And she went and had her mom, and I want to say it was in a Coon Rapids clinic maybe. And they did do it.
How about Mayo?
Yeah, I don't know on Mayo. I do think Mayo does some form of it. I'm just not sure like what.
I think Sanford is doing it to a degree as well. At least they're doing it for their employees and members that work for them.
Good.
Mayo listed one of the tests in their lab catalog back in the day when it was mainly focused on psych testing. They were offering it for profit to do. I mean, just, you know, their labs are for profit, and they were offering a partial testing of this. That was 15, 20 years ago.
Yeah.
How about the VA?
What's that?
Anybody know what the VA is doing?
I
No?
know in their nursing homes they're not.
I'll have to check.
Mhm.
What's the turnaround in when you get the swab to get results? How long does it take?
Usually, so I think that it's usually about 3 days to
Oh.
5 days. Yeah, I
Not
had
bad.
over a holiday. I actually got an email saying this is really gonna run us late. So I have had a couple times where it's been really later than that, but it's not a long turnaround.
Not to compared to anything else.
Right, right.
Okay, this is really a stupid question, but as a patient, how do you actually ask for this? Is it a PGX test? What is that it? Okay.
Mhm.
That's the
Just say
standard.
that, yeah, you want the pharmacogenetics, testing, and that describes that, it's the genetic testing for pharmacology.
And what is the company that you use for that? I don't know that I saw that.
Yeah, so I call it PGX, but they are I want to say integrated sciences. Integrity Sciences is the actual company.
What kind of education is provided to the nurses?
So we have a team of 4 nurse consultants, and in our organization, we do monthly DON meetings. And so the meetings really are about are to DONs, and actually some of the education that you had tonight is similar to what we give to the nurses. We do ask them though a little bit differently, in the sense that we ask that we try to do a lot of education around their communication with the providers, and we ask that they pull this out. We also try to help them through that. They don't necessarily have to read it all, but these are your highlights, because if otherwise they get a little overwhelmed.
There's a question in this chat. What interaction, if any, has been had with the pharmaceutical giants such as BCBS, Optum, etc.?
Yeah, I have not had any. We have in our organization, you know, I think that those, yeah, we have not had any, and I don't know what the future, I'm hoping that the future of getting the word out, the future of making sure that, you know, we're pushing this, that people are asking for it, that it will push like Blue Cross Blue Shield to cover the expense of it or include it in part of their wellness. I have not seen that for patients yet. I don't know if anybody else has.
For Blue Cross of Minnesota, they, for commercial plans, they make it an option for employers to be charged like a PEPM to offer this test, as a covered part of their health plan.
Yeah. I'll tell you, it's if they're charging extra, like I said, the company that I work with, it's like $200-300. It's like,
I think it's also important to remember that this doesn't demonstrate all reactions a person could have to a med, because this doesn't speak to the immune system responses or allergies. This is just the metabolic disposition of the drug based on our
Yeah.
genetics.
well, and it does do some with the other types of the ATM, the things that we talked a little bit about in chemical response. So, and it'll do, you're right. It'll do a little bit of that, you know, in the cellular area. There. So based on, you know, based on those genes, you can see, so the TMPT will look at the kind of the enzyme or the chemical response, which could be where you may have an allergen type of response, but it isn't, it is more a metabolic. So you're right, Savannah. Other questions?
Well, I can do a little commercial for the next meeting, which will be January 25th, because we're going to stick with the medication pharmacy kind of thing. I went to the corner drugstore in St. Paul for my last COVID shot and flu shot, and while I was there, the daughter of the owner, she's her name is Hildy, and she's a registered nurse. And she gave us a little talk about pharmacy benefit managers and what that's doing to your neighborhood drugstore. And she was so good about talking about them, because I've gone to legislative hearings where when they talk about the pharmacy benefit managers, everyone's eyes just glaze over and nobody knows what they're talking about or how to deal with it. And so I asked her if she would come and do a meeting for us, because it's a great time. It's a topic that'll be coming to our legislature again. It's being discussed at the national level, and it would be something we could advocate around. So she's coming next month on January 25th. You can ask her all your questions about Optum and the other lovely people out there, organizations out there. And she's a good speaker. So I think it'll be a really interesting program. And as was this one, this was fascinating. And Martha has her hand up.
It was on public radio today also.
I heard part of it. Yeah.
So people, you can download the podcast and listen to it, but it was very good. It actually was so complicated, I'll have to listen to it over again, because they were talking about the interface between the patient, the pharmacy, the PMB, what is it?
Yeah. PMB.
Pharmacy.
PPM.
PBM.
Yeah,
Yeah.
PBM. And they
Pharmacy
mentioned
management.
Optum, yeah, so lots to learn and very complicated.
Yeah, so I'm excited that Hildy is coming. So anyway, that's the end of my commercial. And Amy, I just think you did a great job. I learned so much
Great.
tonight.
Fabulous. Makes me want to go get tested.
Yes, yes, thanks. It's fun. It's fun.
Well, thanks, everybody. Well, everybody have a great holiday. As I said, you got the report in your inbox today from Kathy. And then you'll get a survey after this meeting. If you complete that survey, you'll get your CEU as well. So, but have a great holiday, and we'll see you in January.
Okay. Thank you.
Thanks.
Thanks, everyone.
Bye.
Bye-bye.
Thanks, Cammie.